And it's 8 o'clock, and I think we should get started. Am I audible everywhere? No difficulty? Good. Okay. So we're going to talk about liver pathology, and I need to turn some lights off so that you can actually see what's happening here. Okay, that should do it. So Dr. Aronian persuaded me to do this a while ago, and I've been working on it ever since, including 5 minutes ago in my office. But anyway, so I want to talk a little bit about normal liver physiology, histology, and what we do with biopsies first, so that we're all on the same frame in terms of our understanding of what the pathology is that I'm going to try to show you. So the liver is a very busy organ. It synthesizes, it detoxifies, and it excretes things as well. It's quite large. It's one of the largest organs in the body. It's typically larger than the brain, interestingly enough, although it doesn't use as much oxygen as the brain. Blood flow, it has a double circulation going into it. Most of this comes from the portal circulation, which of course goes through the intestines and pancreas and spleen first, and then it goes to the liver. And the arterial supply is a minority of all the blood that goes through it. And after a nice big meal, it's even more of that circulation goes through the portal circulation as well. In some ways, having a double circulation protects the liver from having, if one of those circulations is not working, then the liver can still survive, with the exception of the biliary tree, which is supplied only by arteries. It's not supplied by the portal circulation at all. So this is why if there is thrombosis of the hepatic artery following transplantation, the biggest threat is actually to the biliary tree, scarring, necrosis and scarring, and so on. Liver gets about 25% of resting cardiac output, which is quite substantial. Of course, we never know it's there because it's sitting behind the rib cage, right? So anyway, microscopically, the liver on its very smallest level, we call this a lobule. A lobule consists of a portal tract, which is the terminal inflow of the hepatic artery and portal vein, and the beginnings of the outflow of the bile duct, and there's one of these in each portal tract. The blood from the hepatic artery portal vein mixes together and circulates in between cords of hepatocytes from the portal area into what's called the central vein, what's called here THV, but we call it a central vein most of the time. So there's actually a mixture of arterial and portal blood going here. It's interesting that the closer you are to the portal tract or the farther away you are, the hepatocytes, you think the hepatocytes are all doing exactly the same thing, but that's not true. In fact, the hepatocytes have different functions depending upon which zone they're in, with zone 1, zone 1 being closest to the portal tract, zone 3 being closest to the central vein. This is particularly interesting in that zone 3 has enzymes called cytochrome P40 oxidases, which tend to detoxify most things that come into the liver, and metabolizes and excretes. They have the unfortunate effect of most drugs that are hepatotoxic. Actually, once they become metabolized in zone 3, they're turned into toxic agents, and they're only turned into toxic agents when they get into the liver. When there is direct drug toxicity to the liver, it typically occurs in zone 3, and this can be recognized microscopically as well. So double circulation circulates through the hepatic cords into the central vein, different functions to the different areas of hepatocytes. This is normal liver. This is kind of a medium power. Here is a portal tract. You're going to have to take my word for it. That is a portal vein. That's a bile duct. And I think that's an arteriole right there. And this is the central vein. And everything looks pink and blue, right? And it's especially confusing because when we look for fibrosis, that's made of collagen. Collagen stains pink in this as well. So relatively low levels of collagen are difficult to detect with the normal hematoxylin and eosin stain. So what we do is we do special stains. And this is called a trichrome stain. It stains the collagen blue. And it does a really nice job of that if the stain is done properly. And you can see again here is a normal portal tract, portal vein, arteriole, a couple of bile ducts in this particular case. Notice that the sinusoids in which the blood circulates are nice and open. Most of the other cells here are hepatocytes. If there is an abnormal increase in collagen, such as you see here in the portal tract, it stands out very nicely in the trichrome stain. And this would be tough to detect in a standard H&E stain because all this blue stuff would be pink, just like everything else. We also do a stain called a reticulin stain. Reticulin fibers don't stain with H&E or with trichrome stain. There's a silver impregnation stain that is used to detect them. Reticulin fibers line sinusoids and surround the hepatocytes in a very intimate way. It's extremely helpful because if you lose hepatocytes in the liver, you get collapse of reticulin fibers such as this. So it's a very sensitive detector of loss of hepatocytes. And if you lose hepatocytes around the edges of the portal tract due to a process that we call interface hepatitis, inflammation in that area, you can also identify that same collapse. So that's helpful to us. We do an iron stain because it's a little bit tough to see relatively low levels of iron. The iron in this stain is staining blue, and you should actually not see any blue staining at all in a completely normal liver. So this is like a 1+ iron, and this is a 4+ iron. We also pay attention to whether the iron is in the hepatocytes or if it's in the Kupffer cells. Kupffer cells are macrophage-like cells that line the sinusoids that help to remove things from the circulation that nobody wants there. And the iron accumulation that occurs in Kupffer cells is from a different cause, typically hemolytic anemia or transfusions, than the iron that accumulates in hepatocytes. So it's important to differentiate between them. Okay. Hopefully that's the last one. Anyway. And getting back to iron. Getting back to iron, you can see that the iron is actually accumulated in the bile duct as well, which is an important sign of really grossly excessive iron accumulation within the body. Anytime we see this, we'll also we'll send a piece of tissue off for quantitative iron to again evaluate that. And then we also do a stain called a PAS diastase, which stains the globules of alpha-1 antitrypsin deficiency. And we don't see very many cases of this, but every time we miss one because we didn't do a PAS diastase, we feel like crud. So we just do it routinely as on almost every case. In alpha-1 antitrypsin deficiency, you get chronic inflammation and fibrosis. Looks very much like a chronic viral hepatitis. But if you look very, very, very closely, you can see these little pink globules in the cytoplasm of the cells. And this is alpha-1 antitrypsin that has accumulated in the cells because the cells aren't able to export them into the bloodstream normally. They're tough to see in the normal H&E, so we do this stain, which highlights them very nicely. These red globules are the globules of alpha-1 antitrypsin deficiency. And interestingly enough, about once every couple of years, we will unexpectedly find this in a hepatectomy specimen in a patient who has undergone transplant. So it has its uses. Okay, so we get biopsies for a whole variety of reasons. Probably at least half of them are for medical disease, viral hepatitis, drug hepatitis, and so on and so forth. And we do a full group of special stains on these as a matter of routine. And then for other reasons, we restrict them based upon experience and our knowledge of what we really need to know from that. So not every biopsy or every specimen, I guess I should say, gets a full thing. And of course, if a biopsy is for primary metastatic tumor, we don't do any special stains in advance. We wait and look at the H&E and then decide. Of course, usually the issue is there tumor present, and if so, is it a primary or is it metastatic? And we'll use immunostains to help us determine that. So again, typical scenarios for liver biopsy: medical disease, hepatitis C and steatohepatitis are by far the most common clinical diagnoses that lead to liver biopsy. Post-transplant, any kind of elevation of liver function tests will often lead to a biopsy, primary metastatic neoplasm. And the one that drives us absolutely crazy as pathologists is the surgeon's in the abdomen, he decides that the liver looks funny, and he does a biopsy. And what drives us crazy is because invariably there has been no clinical workup of liver disease. So we don't know what the liver function tests are, we don't know what the serology is, we don't know what the viral testing is, and so on and so forth, and we're kind of guessing. As pathologists, we are extremely dependent upon clinical laboratory testing to put us in the right direction, because a lot of things can look like each other in the liver morphologically. So those are really key information that we need to make an appropriate diagnosis. So how do we look at a liver biopsy? First of all, we got to determine, is it adequate? And liver biopsy is typically done with a 16-gauge needle, which is about 1 millimeter in diameter, and it should be 2 to 2.5 centimeters in length. And if we get that, then we will get a biopsy that has anywhere from 10 to 15 portal tracts, which is basically what we need in order to make an accurate diagnosis. If a narrower needle is used, then the amount of tissue, the length of tissue needs to be increased. Otherwise, we get fewer portal tracts, and it gets more difficult to figure out what's going on. There are certain areas where number of portal tracts is absolutely crucial in order to figure things out. Not every lobule in the liver looks exactly the same as every other lobule. There's usually a range of changes from one lobule to another, from one portal tract to another. So we need to see a good range in order to understand how much disease process there is. There's also an interesting thing that not every biopsy of the liver is going to yield the same diagnosis exactly, because you think the liver is going to be fairly uniform throughout, but it's not. But it's not in a very inconsistent way. So we don't know if we biopsy the right lobe or if we biopsy the left lobe, they're necessarily going to be different in exactly the same way. They may or may not be, but it's not consistent. Okay, understanding the architecture, you really have to have a pretty firm idea in your mind of what the normal should look like in order to be able to recognize that something is abnormal. So I tell our residents, not every fibrous area is a portal tract. You could have fibrosis outside of a portal tract. You can have a bile duct outside of a portal tract as well. Architecturally, there's usually an approximately 1-to-1 ratio of portal tracts and central veins in a biopsy. And if they're off in some way, then something is not right, okay? And if we look at a typical biopsy, this is what we see. We get this narrow core of tissue. This P means portal tract, this means central vein. And normally there should be a relatively similar distance between them as well. And if that's off, then you have to recognize that something is not right. And then you have to kind of systematically go through the biopsy and identify what the changes are in specific areas of the biopsy. It's not just a matter of taking a quick look and recognizing what the disease is. So we looked at, are the sinusoids visible? Are they wide open as they should be normally? Or did the hepatocytes look as if they're piled on top of each other? What about changes in hepatocytes? Is there steatosis, fat there? Ballooning is a degenerative change in hepatocytes in which they get larger. Acidophil body is a dead hepatocyte that's undergone apoptosis, in other words, suicide, as a result of recognizing some kind of abnormality. We look for pigments. We look at things like Mallory-Hyalin or alpha-1 antitrypsin globules and so on. We look to see what is the character and location of inflammatory cell infiltrate. Is it portal? Is it lobular? Is it mononuclear cells? Is it neutrophils? Is it plasma cells? And so on. Are there increases in Kupffer cells? Is there fibrosis present? So we have to go through this all, check all these things off on our heads as we're going along through the biopsy. So this is a normal liver. Again, notice that the sinusoids are wide open. All the hepatocytes look identical to each other. The nuclei are all the right size. And then this is a liver with acute hepatitis, in which, notice the way all the hepatocytes are just kind of piled on top of each other. It's a classic hepatitic picture of that. This is a Councilman body. Here's another one. Acidophil body. These are hepatocytes that have undergone suicide apoptosis and have become necrotic. And there's probably a little bit of hepatocyte ballooning as well. Right here, it's a little bit larger and the cytoplasm is cleared. Again, all these things suggest to us different things, but I'm not going to go into what each one suggests, but they do suggest us different etiologies depending upon what's present in the biopsy. These are a couple of examples of portal inflammation. Notice in this one, there's kind of nodular in appearance. It's not uniform. It's all small lymphocytes. That's classic for hepatitis C, but not always. And this one, it is more diffusely present. There are large and small lymphocytes. There are plasma cells. There are eosinophils. Again, the character, the type of cells that we're looking at help us determine what the etiology might be in a particular case. Okay, so now let's get on to some pathology. That's 20 minutes of holy cow. Okay, 20 minutes of normal and what we actually do with these things. So we're going to talk about donor liver pathology, acute and chronic rejection, recurrent liver disease, and de novo liver disease. And there's a lot here, believe me. Okay, so donor liver biopsy is done on the donor liver at the time of transplantation. It's very important for us as pathologists because it sets a baseline. And I think it's important for the clinicians because it gives some early clues as to what the liver function is going to be in the first few days after transplantation. So we look for evidence of fibrosis in the donor. We look for steatosis, and I'll go into that a little bit more later. Sometimes there can be necrosis and acute inflammation, particularly if the donor experienced ischemia or hypoxia prior to donating liver, we look for features suspicious for hepatitis C because sometimes a hepatitis C positive liver will purposely be transplanted into a patient with hepatitis C simply because that's the liver that's available. But of course, the surgeons never tell us that. So we have to be careful to look for these things and not miss them. And we look for other infectious disease, granulomas, and so on and so forth. Typically, the most common thing that we see is some steatosis, and all the other things that we see are relatively uncommon. So steatosis is an important factor because if there is more than 50% macrovesicular steatosis, that liver is likely to do poorly after transplant. This is one reason why frozen sections are done at the time of transplantation to rule this out, and why we look at this very carefully afterwards as well. So macrovesicular steatosis, single large globule in the cell. Microvesicular steatosis has multiple globules. It does not have the same significance in terms of liver function as does macrovesicular. And then we've got this thing which I've named paucivesicular steatosis, which you get a single small globule within the cell, which it clinically is insignificant, does not have importance. If you have a combination of macrovesicular steatosis, quite a bit of it, and you have evidence of hypoxic ischemic damage, central lobular necrosis, you get this thing that's called lipopiliosis. What has happened is the dead cells, dead hepatocytes, have released their lipid. The lipid is out in the sinusoids, and once it's in the sinusoids, what's going to happen? Well, what's going to happen is it's going to get into the peripheral circulation. So you've got fat in the lungs, in the lung capillaries. You've got fat in the brain. You've got fat in the glomeruli of the kidney, and this is a fat stain showing the same sort of thing. And this can be a significant cause of Clinical problems after transplantation. We also have at least one autopsy-proven death. That's where these photographs came from in one case, and perhaps one other as well that was not autopsy. So recognizing lipopeliosis is important in terms of helping the clinicians recognize that there may be a problem that isn't clear to them as to what's going on. Okay, yes?
When does that particular tissue received for you? Is it before they remove the old one? Is this when the liver arrives here, or how do you?
No, it is done at the time of transplantation itself. It's sometimes called a 0-hour biopsy.
So they don't have the benefit of any of this information when they're actually
No,
putting it? Okay.
not unless they decide to do a frozen section at the time of transplant. And we can give an immediate, but the surgeons here don't do that very often. So, good question. Okay, so let's talk about all the things that happen after transplantation. And we get biopsies for a variety of reasons. I'll talk about what preservation changes means, acute and chronic rejection, recurrence of original disease process, and then brand new liver disease that has nothing to do with what had happened to that patient or liver beforehand. So, as pathologists, we do have some difficulties in interpreting post-transplant liver biopsies. They're a real challenge, and they take a while to get accustomed to. One of our problems is in our institution, we do not what are called protocol biopsies. Now, some institutions will do one biopsy a week for the first month, and then one biopsy a month for the first half year, and so on and so forth, so that there is a consistent series of biopsies and can recognize changes more readily. So if we're only doing biopsies when the patient is not so well, then it's a little more difficult to follow progress in there. So we don't have a baseline beyond what the 0-hour biopsy gives us. This also means that the pathologists don't, unless you're in a center like ours where we're doing many transplants a year, if you're not in such a center, that means the pathologist doesn't see these biopsies very often and has difficulty learning how to interpret them. And also, only the clinically most difficult cases tend to get biopsies. So oftentimes, for instance, if somebody is suspected of having acute rejection, they'll get treated for acute rejection, and if that doesn't seem to be working well enough, then the biopsy is done. And of course, the treatment's going to change. What we see in the biopsy makes it a little tougher. Anyway, I know these are a lot of excuses, but anyway. Clinical history is key, as I mentioned earlier, and very important. Adequacy of biopsy. It just kills us as pathologists if we get an inadequate biopsy. Also, even though we look for the clinical history and liver function tests, they may be significantly worse than what the biopsy looks like. So there isn't always a one-to-one correlation between those. Major challenges, distinguishing acute rejection from recurrent hepatitis C, and this thing called plasma cell-rich hepatitis, which I'll explain a little bit more. Most common diagnoses, 0 to 30 days post-transplant, preservation changes, and acute rejection. 30 to 90 days, acute rejection, and recurrent hepatitis C. You have to realize what something like 80% of our transplants are done for hepatitis C, so it's by far the most common cause. And after 90 days, the most typical recurrent hepatitis C, other disease recurrence, such as primary biliary cirrhosis and so on, and acute or chronic rejection. And of course, I always tell the residents, more than one diagnosis may apply to any one particular biopsy. So don't just be satisfied with being able to make a single diagnosis and ignore everything else that is there. So preservation changes include a whole variety of things. The steatosis lipopeliosis is one, ischemic necrosis is another, but these happen prior to the actual transplant itself. This thing we call post-transplant cholangitis probably happens after the transplantation, and it looks like, morphologically, it looks like major duct obstruction. We get expansion of the portal tract with edema and inflammation, increased numbers of bile ducts, inflammatory cells, neutrophils in the bile ducts themselves. It looks just like major duct obstruction. And it may reflect functional obstruction of the biliary tree. So even though a radiologic picture shows it to be completely open, there still may be functional obstruction, which is possibly causing this. Fortunately, it does resolve spontaneously. It takes a week or 2 or 3 for that to resolve, but we still see this on occasion in biopsies. Acute rejection has some very classic features. You typically see it anywhere from 2 weeks to 6 months post-transplant, most commonly, but it can be seen late afterwards. The classic morphology is there is lymphocytic damage to bile ducts, so you don't see a nice, neat wreath of nuclei around the bile duct. Here's another one that doesn't look as if it's doing too well. We see endotheliolitis, which is lymphocytic infiltrate lifting up the endothelium, as you can see here, and eosinophils are a prominent part of the infiltrate. I guess I really should put here there is portal inflammation with all of these things seen. These are classic features. You can imagine, though, that if somebody has received anti-rejection medication before the biopsy, a lot of what we're expecting to see actually gets suppressed by the medication. A little tougher to make a diagnosis. One of the things I tell the residents is look at the biopsy at low power. If the sinusoids are nice and open like this, all the hepatocytes look the same, you don't see degenerative changes in the hepatocytes, and everything's happening in the portal tracts with this inflammation, you're probably dealing with acute rejection and not with recurrence of some disease process that affects hepatocytes. One little exception is you may, in addition to seeing portal damage, you may also see endotheliolitis and hepatocyte dropout secondary to inflammation in the central lobular area. This is typically a reflection of severe rejection. We don't see this terribly often. We might see maybe one spot in a biopsy. We have criteria for grading it. We happen to use the Banff criteria, which grades mild, moderate, severe. I like simple things. Some people use rejection activity index, which grades the inflammatory infiltrate, the extent of duct damage, and endotheliolitis separately to arrive at a particular score. Too complicated for me. Some consider any central lobular damage to be severe rejection, certainly is significant. The practical issue is it rejection or is it something else? Is rejection present or is something else going on in the liver? And that is most far. So even a mild rejection will be treated in a patient. Now, plasma cell-rich hepatitis is a special type of lesion that is seen relatively late stage. It doesn't occur during the first 6 months typically, but typically a good bit later. There's controversy as to exactly what it means. It was first thought to reflect autoimmune hepatitis, actually brand new autoimmune hepatitis occurring in a patient who's never had autoimmune hepatitis before. And the reason for this, there are many plasma cells present in the infiltrates, and it responds very nicely to steroids, which are typically used for autoimmune hepatitis treatment, which of course do very well. They're not exactly the same as autoimmune hepatitis. Morphologically, there's only very mild portal inflammation, and there's very marked central lobular inflammation. So it doesn't exactly look the same as well. There's a very high risk of graft failure and death in these patients. So the real question is this thought to be, is this a autoimmune hepatitis, or is it actually an expression of rejection? Now, some of these patients do have donor-specific antibodies running around, for instance, in their circulation. I think that this one, I think a lot of people think it actually reflects rejection, but I don't think this is really for certain. Can also be mimicked by other disease, such as happened to us once in a case, EBV-induced post-transplant lymphoproliferative disease, in which the cell type was almost all plasma cells rather than lymphocytes in this particular case. And we kind of went down on that one. But anyway, eventually it got figured out, but it can be mimicked by other disease. So it's a special type of infiltrate of an inflammatory lesion that is seen typically in transplants. It's not only seen in liver, it's also seen in kidney transplants, where the kidney people are convinced that it represents rejection. Not quite as certain in liver. Now, chronic rejection typically happens later, and can be, presents its own challenge in terms of making a diagnosis. The key thing is patients lose bile ducts, so they develop a cholestatic type of picture as far as their liver function tests are concerned, particularly in regards to GGT. Ductopenia is defined as having bile ducts in fewer than 50% of portal tracts. Normally, there should be a bile duct in every portal tract. But you can imagine, though, if you have a biopsy that has only 5 portal tracts in it, and you're trying to count portal tracts, you cannot get an accurate picture as to whether you truly have ductopenia or not, just because they're missing in 2 out of 5, for instance. So adequacy of other biopsies is extremely important in here. There's pericentral fibrosis rather than portal fibrosis, and obliterative vasculopathy as well. Acute and chronic may coexist in patients. Progression to chronic can be very rapid. Fortunately, if you have ductopenia only, that appears to be reversible, but other features are not as reversible. Here's an example of what we see. This is actually a portal tract. There's a little bit of portal fibrosis, but most importantly, there's no normal bile duct present in here. And you go through somebody with well-developed chronic rejection, and you will see maybe 1 out of 10 portal tracts with a bile duct in it. And other bile ducts may have what are called atretic bile ducts. They've undergone some kind of degenerative change, not completely gone, but they don't count. This is endothelial endothelial proliferation in an artery. This is foam cell change in a major vessel. Unfortunately, these larger vessels don't show up in liver biopsies, so we don't see them. We only see them in a hepatectomy specimen later on if the patient is retransplanted. This is pericentral fibrosis, which is more typical of of chronic rejection. This can also be seen in plasma cell hepatitis, so it's a little bit of area of confusion. Okay, problems with the biopsy, distinction from recurrent disease. This is especially true in somebody whose original disease process was primary biliary cirrhosis, because those patients have ductopenia to begin with, and as they recur, they develop ductopenia all over again. Biopsies with less than 10 portal tracts, confusion of atrophic bile ducts with duct proliferation, confusion of portal and central lobular areas, because these central lobular areas become fibrotic, and you have to be careful not to call it a portal tract and say, oh, there's no bile duct there. And these larger vessels don't show up in the core biopsy. So we usually able to make a reasonable diagnosis, a reasonably accurate diagnosis of chronic rejection, but it has its challenges, as do most other things. So acute versus chronic rejection. Acute rejection has bile duct inflammation. This has atrophy and pycnosis. Portal inflammation is present. Acute rejection, chronic rejection, not significant. Central venous lysin inflammation may be present. This has obliteration and fibrosis. They may coexist in the same patient, so you have to look out for both of these. Okay, let's talk about now post-transplant disease recurrence. And of course, the most common recurrence is going to be hepatitis C. That is the cause of transplantation in majority of patients that we see, and 100% of patients recur. And of course, they can be treated after that, but they're going to recur before they get treated. Other things that recur commonly: primary biliary cirrhosis, primary sclerosing cholangitis, and autoimmune hepatitis, all commonly will recur in a transplanted liver. Less things that will not: alpha-1 antitrypsin deficiency. This is a problem in the hepatocytes in the recipient liver. We've actually had one example, which we presented here several years ago, of a donor liver unexpectedly having alpha-1 antitrypsin deficiency and causing disease in the transplant liver as a result of that. Biliary atresia is the most common cause of transplantation in infants. Does not recur in the transplanted liver. And the frequency with which alcoholic liver disease varies. I think that's as much as I could say about that. So again, hepatitis C is 100% recurrence. The clinical course is highly variable. Patients can go downhill fairly rapidly, and they can go on for years and years and years with recurrent hepatitis C. Now, with adequate treatment, chemical treatment for hepatitis C, this is becoming less of a problem. Risk factors are, as I suggested here, but if there is no treatment, around 25% will redevelop cirrhosis in about a 5-year period of time, which is much more rapid than the classic, than the patients experienced before they were transplanted in their native liver. And of course, the most likely reason for this is that these patients are immunosuppressed. And immunosuppression definitely has an effect on what happens in the liver with recurrent hepatitis C. This is a big issue for us as pathologists, is determining what constitutes acute rejection and what constitutes recurrent hepatitis C. And of course, we're very interested in knowing what the clinical parameters are, what the viral load is, and things of that sort as well. Generally, I think we're pretty good at differentiating between these two. If a patient has been treated for rejection, though, and a patient who had rejection has been treated for rejection but not completely, that's probably the most common time when we have difficulty distinguishing between these. And there are some features that are common between these. For instance, bile duct attack. Hepatitis C does have lymphocytic infiltrate in bile ducts in about 40% of native livers. Eosinophils can be present in hepatitis C. They're frequently present, but usually very, very few, and so on in these features. So usually we can make this distinction between these two. These are examples of recurrent hepatitis C. Again, notice that the liver cells are piled on top of each other. There are lymphocytes present within the lobular parenchyma. If we look at the reticulin stain, we can see evidence of collapse present here. There is what is called interface hepatitis, which is extension of the portal infiltrate into the surrounding lobular parenchyma with loss of hepatocytes and development of fibrosis. And every once in a while, the portal tracts will be so crowded with inflammatory cells that even though this is hepatitis C, it looks a little bit like endotheliolitis. So we have to be careful how we interpret that. And you can see there's a lymphocyte here in this bile duct as well. So potential for confusion. And there's a couple of eosinophils as well in this particular one. So there's potential for confusion between the two. Usually we can make the distinction, but not always. There is a variant of recurrent hepatitis C called fibrosing cholestatic hepatitis. It was actually initially described in liver transplants of patients with recurrent hepatitis B. But in these patients, clinically, they develop very marked increase in transaminases, but they also develop a cholestatic profile as well as a result of having such severe hepatitis. It is one of the forms of recurrent hepatitis C. It can also be seen in hepatitis C in the native liver in somebody who is immunosuppressed. So if somebody has AIDS and hepatitis C, they can develop this as well. The immunosuppression has a profound effect on what's happening in those patients. They have a very rapidly progressive clinical course, liver failure in weeks to months, very high viral titers as well. So it's really just a very, very severe form of recurrent hepatitis C in these patients. Here's an example of a patient who was transplanted in January. The biopsy in February, about 6 weeks later, this reflects a tremendous amount of intralobular collapse. And the hepatectomy in November, 8 months later, showed cirrhosis at that point already. So it can go very rapidly. We don't see this very often. It's something that clinicians, I think, more concerned about overall. Differential diagnosis, acute cellular rejection, cholestatic drug reaction, major duct obstruction, ischemic injury, leading to duct. All of these things feature into this because all of these can cause a cholestatic type of picture as well as having elevated transaminases. Okay, primary biliary cirrhosis does recur very frequently. Primary biliary cirrhosis is an autoimmune disease process in which the most prominent thing that you see morphologically and clinically is loss of bile ducts. So they literally lose ability to excrete bile from their livers. The recurrence looks very much like what we've seen in the native liver with ductopenia and a very slightly hepatitis-like picture. Antibodies, antimitochondrial antibodies are seen postoperatively, so they do correlate with that. Liver biopsy is again, the gold standard for making a diagnosis in these patients. And in institutions that do protocol biopsies, like they'll biopsy once every 6 months or once a year, they will actually see morphologic recurrence prior to identifying a clinical recurrence in patients. Immunosuppression probably suppresses the amount of disease going on in patients. So this is a recurrent PBC. You can see in the portal tract is very intense chronic inflammation. This is a little bit higher power, but there's no bile duct present. This is an arteriole. This is an arteriole. Here's a portal vein. There looks like interface hepatitis present, but there's no bile duct. Here, and PBC is also notable for having granulomas, non-caseating granulomas, collections of histiocytes in the portal tracts, sometimes also involving the bile ducts. And this is a classic example of what's called a florid duct lesion with the granuloma and lymphocytic infiltrate kind of blowing through the wall of this bile duct. It is, if you see this, it is almost diagnostic of primary biliary cirrhosis and extremely helpful when making a diagnosis in the native liver, to say nothing of in the transplanted liver. Differential diagnosis gets to be quite broad, and there are infection, drug toxicity. We blame everything. Any time that pathologists cannot figure out what the etiology is, we usually blame it on drugs. I will put a comment say, drug toxicity cannot be excluded, and that's that's what it is. Can't be helped. Sarcoidosis, which is idiopathic granulomatous, non-caseating granulomatous disease, can give the same kind of features. Hepatitis C, again, can give you lymphocytic cholangitis, and here we're blaming drug effect as well on this, or acute chronic rejection. The biggest major differential is differentiating recurrent primary biliary cirrhosis from chronic rejection, because both of them are going to have ductopenia present. So we look for evidence of a hepatitis-like picture in PBC, granulomas, which are typically not seen with hepatitis C, Predominant inflammatory cell is mature lymphocytes, which doesn't help us, but no endotheliolitis in PBC. Chronic rejection, inflammation is usually only in the portal tract, lymphocytic cholangitis, pericentral fibrosis, which is typically not seen in primary biliary cirrhosis. After all that is said, we still have a lot of difficulty distinguishing these two disease processes and making sure we can make an appropriate diagnosis. Other things that recur, primary sclerosing cholangitis. It's a little bit controversial as to whether it recurs. I think most people accept that it does. Immunosuppression that is used for the transplant does appear to suppress this. So it's taken a while to get enough cases to be sure that it really does recur. Primary sclerosing cholangitis most commonly affects major bile ducts. It causes strictures and dilations. If you have ischemia, remember I said that the hepatic artery is what supplies the major bile ducts. If you have loss of arterial supply to the liver at any point, it can give you scarring in major bile ducts. It looks exactly like primary sclerosing cholangitis from a radiologic standpoint. It's very difficult to verify by a biopsy because the major problems are in the major bile ducts, not in the minor ones, typically. And chronic rejection can give you a problem as well. I'll show you, let me move on, show you examples of what we'd like to see in primary sclerosing cholangitis in a biopsy. This is called periductal onion skinning. It's a very characteristic fibrotic lesion around bile ducts, or you lose bile ducts and get fibrous nodules present. Typically do not see this in a biopsy, core biopsy, because it's so widely scattered in the liver and there's so little of it that you really can't do it. Both of these photographs were taken from hepatectomy specimens in which we had lots of liver to look at, multiple sections to look at to find this relatively uncommon lesion. Let me get back to this. Autoimmune hepatitis recurrence is quite common in patients. The autoantibodies that are seen in serologic testing before transplant, they persist afterward, continue to be made. Biopsy findings can be mistaken for other diseases. Immunosuppression probably does modify this and make it less severe, particularly in adults. And I think this is an example of recurrent autoimmune hepatitis. And usually there's a lot of damage. Autoimmune hepatitis, when we see it in biopsies and we see something that is really very, very severe inflammation with a lot of, with a lot of interface hepatitis and many plasma cells, we're pretty sure that we're dealing with autoimmune hepatitis. And these are all plasma cells present here. Remember I mentioned this process called plasma cell hepatitis, which is what we get confused with, whether it's really autoimmune hepatitis or plasma cell. Fortunately, the treatment is going to be very similar for the two of those, so either diagnosis is helpful. And again, this is, okay, let me just back up a bit. Okay, so one last thing, and this is de novo disease in the liver, something that was never there to begin with in the recipient native liver. One of these is called idiopathic post-transplant hepatitis. It's a chronic hepatitis that cannot be attributed to any kind of recurrent disease. This was described first in children who were transplanted for biliary atresia. Biliary atresia is a congenital disease. It has no known relationship to viral hepatitis or anything of that sort. So there's nothing in that original patient's disease process which ought to lead to chronic hepatitis. And this is a chronic hepatitis in patients. Incidence becomes more common with additional years of follow-up, so you can imagine that it's much more likely to affect children than it is to be identified in adults. And it's also it was actually first identified, It was actually first identified in institutions where protocol biopsies are performed, once every few months as well. And they were identifying abnormal findings in the biopsies prior to actually identifying any abnormalities in liver function tests and so on. The changes in liver function tests came later on in these patients. In children, the biopsy findings were very, very common. And they did lead to graft failure in a significant percentage of patients. This is graft failure that happens over many years period of time. It's not like not a rapid event. So this is something brand new. Nobody knows what the etiology is. Some of these patients may have donor-specific antibodies running around. It may be a form of rejection, but it's never actually been demonstrated, proven to be. So these are just various causes in patients, which I think we have discussed as well. Right, okay. So that concludes my presentation. Things to just take away from this: recurrent disease is by far the most common cause of late post-transplant dysfunction. We rely absolutely on adequate clinical information, liver function tests, and so on and so forth. And the longer it is post-transplant, the more likely you are to get a hedge pathologic diagnosis, because more and more things can begin to look like each other in these livers. So that's an interesting message, I think. Okay, got a couple minutes for questions if anybody has anything. Yes.
You referred to